Hello everybody, welcome to this educational lecture series called Know Before You Go. We will ask the questions. This is designed for medical students on their surgery rotation. You gotta know this information before you go to the surgery, because once you get in the surgery, the surgeon's gonna ask you a question on the spot and you're not gonna know it. So I'll be asking the questions, you answer them as we go along. First episode's about cholecystectomy, gallbladder pathology, everything you need to know before you get into that operating room and take out somebody's gallbladder. I will say, I hope the comments on these can be residents and medical students commenting on questions they've been asked in gallbladder surgery, and we can kind of share this information so that student that goes into a surgery is prepared and they can answer pretty much any question that a surgeon would ask them within reason. So, here's our gallbladder. Here's our liver. What's the name of this duct? That's the cystic duct. What's the name of this duct? That's the common hepatic duct. What's the name of this duct? That's the common bile duct, okay? What do we call stones in the gallbladder? Stones in the gallbladder. That's cholelithiasis. Cholelithiasis. What do we call stones in the common bile duct? That's choledocholithiasis, okay? So just some important definitions to get started here. Now somebody comes in, you get a consult from the ED, and they say, we think this patient has cholecystitis. First thing you're gonna do is get that right upper quadrant ultrasound, okay? There's really 3 findings on the ultrasound that will help tell you that it's cholecystitis. Think about those right now, okay? What are those 3 findings, okay? One is pericholecystic fluid, so there'll be fluid around the gallbladder. Number 2 is a thickened gallbladder wall, okay? So typically 3 millimeters is what we call a normal wall. If it's greater than 3 millimeters, that's concerning. And number 3, well, obviously gallstones is a telltale sign, okay? And also a positive Murphy sign. So that's kind of an extra one. That means when they press the probe in this area on the right upper quadrant, they're gonna have pain there, okay? So, you worked it out, you got cholecystitis. Sometimes you'll have a patient come in, they'll have elevated LFTs and an elevated bilirubin, okay? That means they likely have choledocholithiasis, okay? That stone, I guess, what would you do for someone with choledocholithiasis, okay? The answer, the standard of care today would be an ERCP. If you want an ERCP, you want to call your GI colleagues so that they can go in and extract the stones, okay? If one of these stones gets stuck and causes an infection, what is that called? That's called ascending cholangitis, okay? Cholangitis, ascending cholangitis. Again, you want to do ERCP, get that stone out, obviously start them on antibiotics. There's 3 main findings for cholangitis, okay? You gotta know those 3. We got, this is the Charcot triad. Charcot triad. Okay, so what's Charcot's triad? Right upper quadrant pain, okay? Jaundice, and obviously, not so obvious, fevers. Okay? And then if you have the pentad, which is Raynaud's pentad, then they're really sick. This is altered mental status and hypotension, so that makes the pentad. Okay? They need an ERCP, they need to get that stone out, get healthy, and then you take out the gallbladder. Other thing that can happen is stone gets stuck right about here, and then the patient can also have pancreatitis with that as well. Elevated lipase, amylase, and this obviously, the pancreatic duct and the common bile duct empty at the ampulla, elevator into the duodenum. Okay, so that's something you gotta know. Okay, it's good. That's a good start here. It's a good start. Another thing I should mention is how thick is a common bile duct typically? Okay, how many millimeters is a common bile duct normally? should be less than 6 millimeters. That's greater than, less than 6 millimeters. If it's greater than 6 millimeters, that's a concern that someone may have cholelithiasis. But as you age, that standard can actually go up. So I think it's maybe about 50 years. After 50 years, every 10 years, you gain millimeters. So someone who's 90, they can have a 1 centimeter common bile duct, and that's actually can be normal for them. Okay. The other thing you got to know is if someone's in the ICU super sick and it's not safe for them to be a surgical candidate, just call IR. They'll put a tube in the gallbladder and drain it out temporarily until you can eventually take out their gallbladder safely. That's called a PERC Coley tube. Okay. Okay. Top 3. What are the top 3 bacteria that cause cholecystitis? Top 3 bacteria: E. coli, Klebsiella, and Enterococcus. Okay, those are top 3. Okay. Gallstones is one of the most common causes of acute pancreatitis. What's number 2? That's alcoholism. So gallstones, alcohol, pancreatitis. Okay. So this kind of takes care of the workup, who to take the OR, how to take the OR, how to work them up, everything you need to know when looking at the imaging and such. Okay. Now we're actually in the OR. You've probably already been asked these questions before the OR. You might be asked them in the OR. Now we need to talk about what you're going to be asked in the OR, okay? Let's start with the blood supply of the gallbladder, okay? So here's the aorta way down here. Let's call this the celiac trunk, okay? The celiac trunk. That has 3 main branches, okay? What are the 3 branches of the celiac trunk? You gotta know this. They're gonna ask you. We got the splenic artery, we got the left gastric artery, and then we got the common hepatic artery, okay? Common hepatic is obviously the one we're most concerned about right now, because it'll split, turn into proper hepatic, and then eventually go up and turn into the right hepatic artery and the left hepatic artery. And off of that right hepatic artery, that's where you'll get your cystic artery, okay? Which is the one you want to know. When you're doing a cholecystectomy, there's something called the critical view of safety. That is what you want to do before you clip anything. Worst thing you can do in a cholecystectomy is cut the common bile duct or the common hepatic duct. And the way you do that is with all the inflammation. Sometimes things can get stuck up to the gallbladder, get stuck up to the cystic duct, and you can accidentally cut them. It's like a 0.01% chance, but still, you don't want to do that. Or 0.1%, I think it's 0.1%. Either way, let's talk about the critical view of safety. Critical view of safety. 3 steps to obtain critical view of safety. 1, dissect the peritoneum off of the gallbladder. Then you want to dissect the lower third of the gallbladder off of the liver. And then you want to see 2 structures, and only 2 structures going into the gallbladder. And what are those structures? Of course, it's the the cystic duct, not the common duct. Cystic duct and cystic artery. Those are the 2 structures you're going to clip before you take off the gallbladder. That's how you get the critical view of safety. And if you look here, you'll see a nice view of the Charcos triad, or not Charcos triad, of the hepatocystic triangle. And you'll see cystic duct here, you'll see common hepatic duct here, and then the liver edge here, okay? And typically the cystic artery runs through this, like right here somewhere. Okay? So, those are my main points today. Know before you go, you gotta answer these questions. Comment questions you've been asked in a gallbladder surgery, and help the classmates out. So then when they get asked it, you know, we'll know before we go. We will ask the questions. All right, thanks for watching episode 1. We're gonna try to get an episode on pretty much any general surgery topic that exists so that you can know before you go.